All right, today we're going to go over tolerance testing, which is another preparatory procedure before initiating any of the treatment protocols on the Cox table or in the Cox technique. First, do no harm, but very important with these delicate disc-related disorders that we don't create an iatrogenic reaction and potentially stir things up and make it worse for the patient. And that's easy enough to do if we follow protocol. We have something called tolerance testing. So prior to utilizing this Cox flexion distraction technique, the patient's tolerance to the procedure is checked, and then you're going to document it. In a sense, it is a medico-legal procedure that will protect you in case there's ever any question as to whether or not the patient was appropriately treated. There are three phases to tolerance testing. We have central, lateral, and then central with the restraints, and we'll go over each one of those. The basic objective of tolerance testing is to find a treatment start point, a place that we can begin to initiate flexion distraction that is not going to aggravate the condition and is going to begin to assist in the healing process. To find the treatment start point, we need to answer two questions. One is, can the patient handle the addition of the restraints? So on the ankle section, we have restraints that will firmly grasp the ankles and create a significant addition to the amount of traction that the patient is going to receive. So can they handle these restraints? The second question is, how much pressure from the treating doctor can the patient handle? Do they need a light amount of pressure, a medium amount of pressure, or heavy pressure? And that's what we're going to discover right now. And that will lead us to the treatment start point for this particular individual or this particular case. Line of drive for about 99% of all of the Cox procedures is 2/3 I to S, 1/3 P to A. There's only one exception to that, and we will discuss that as we proceed along with our instruction. But the contact is made with the beefy part of the thenar eminence, and it's made directly onto the spinous process in most cases. Occasionally the zygapophyseal joints will be contacted. We'll discuss all that. But the line of direction is 2/3 I to S, 1/3 P to A, so you've got more I to S than P to A. This gives you a tremendous amount of leverage over the vertebrae, regardless of your size, whether you're small and petite or a big, large individual, you will have enough leverage to perform this procedure. Very important concept, and that's the barrier of elastic resistance. And the barrier of elastic resistance is the initial tension point of tolerance testing for basically all of the protocols. It's the point where the soft tissue elements in and around the joint have become fully taut. Another way of looking at it is pre-loading the segment. Quick animation to show you what the procedure should look like. And then we'll go ahead and begin to perform it.
This shows the computer animation of the flexion distraction procedure. This was done using Autodesk 3D Studio software and Viewpoint geometric data. Virtual table and virtual patient and the spine are animated. As the table is moved down, the joint is distracted, creating a facet gapping and movement. Here the movement is shown exaggerated.
Okay, so basically, when we contact a vertebrae, we use the thenar eminence, and the blue one would be the vertebrae vertebrae being contacted, and the disc under it would be the one distracted. A lot of this will be cleared up in lab and also in lecture. So tolerance testing, we have 3 phases. The first one is central. Perform central tolerance testing. Again, properly position yourself. Carefully release the table. With your thenar eminence, you're going to slide off of the sacrum and you're going to lock into the L5 spinous process. We're going to start at L5. You're then going to get your center of gravity over the patient so that your arm is going straight up the y-axis of the spine. None of the joints are bent in your arm. It basically serves as a rigid, almost like a fire poker or a pole or a rod. So wrist is locked, elbow is locked, shoulder is locked. And then you're going to get your center of gravity over the patient. You begin a scissors type movement. So whatever pressure you put down with your contact hand, you also put that same pressure down with the tiller bar hand. So you begin to do that, and what you're looking for is the barrier of elastic resistance. And it's that point in this particular case where all the soft tissue elements between L5 and sacrum are fully taut. That would be the barrier of elastic resistance. Once we find that, we go slightly beyond that point. We hold for 4 seconds. During that 4-second interval, we play with the amount of pressure that we're applying to the patient's spine by shifting our body forward. As we shift our body forward, the patient is going to feel more and more pressure in that area, and we see if they can handle light, medium, or heavy amount of pressure. So we're looking for provocation. We're looking for signs that that's too much. Maybe the erector spinae contract, or the patient even groans or grunts, whatever. And then we know we've gone too far. So again, thenar eminence, slide up the sacrum, lock in 5th lumbar, get yourself centered over the patient so that your arm is straight up the y-axis. Equal scissors movement. Find the barrier of elastic resistance, go slightly beyond it, and hold for 4 seconds and play with the pressure. Go from light to medium to heavy. Of course, we're dealing with a non-acute patient, so she's going to be able to take just about any amount of pressure that we apply. Most patients are likely going to fall into the realm of light, but that's something you need to discover through this procedure. So once you've done the 4 seconds on L5, you release, you gently ratchet up to L4, and you do the same thing again. Make sure everything's lined up, equal scissors movement, find the barrier of elastic resistance, go slightly beyond it, hold for 4 seconds. During that 4-second interval, try different pressures. Always inquire for provocation by asking the patient. You say, Shannon, is that too much pressure? Is that too much pressure? Is that too much pressure? And also notice body language. Notice what the patient is doing. You now release L4 and you ratchet up to L3. Do the same thing, L2, L1. And that would complete your central tolerance testing. That would give you an idea of the overall terrain, even though when we start this procedure, we're only going to distract one segment. It gives you an overall idea of the patient's tolerance to this procedure. We're then going to embark on the second stage of tolerance testing, and that's lateral tolerance testing. We're now going to get to the side of the vertebrae into the posterolateral region of the disc, which is the most common area for disc injuries to occur. We'll also be over the facet and basically testing those tissues. We start with the uninvolved side. So if the patient had a lumbar spine disorder with a right lower extremity involvement, we would start on the left side. Okay? So basically, let's say she has an L5 disc with an S1 radiculopathy or S1 sciatica. We're going to start on the left side. Now what we do, instead of grabbing the tiller bar, is we grab the ankle on the side we're testing, or grab the lower leg, whatever is comfortable for you. We're now going to go just lateral, just to the left side of the spinous process. We're going to slide off the sacrum and try and hook into the L5-S1 Z joint, zygapophyseal joint, facet joint, whatever you want to call it. Get your center of gravity over the patient and equal scissors movement. Find that area of elastic resistance, go slightly beyond it, and try different amounts of pressure, light, medium, heavy pressure. Inquire for provocation, ask the patient how they're doing, and also look for body language. Release, move up to the L4, L5 facet, do the same thing. Make sure you're centered over the patient, find the area of elastic resistance, go slightly beyond it, and inquire for provocation. And then you will work your way up the left side of the lumbar spine, going from facet to facet until you get to the L1, L2 facet. You would then duplicate that procedure on the involved side, or the right side. So now you'll grab the right ankle, you'll slide off of the sacrum just to the right side of the spinous process, lock in the right L5-S1 facet, get centered over the patient, lock your arm in, and equal scissors movement, go slightly beyond that, play with your pressures, and inquire for provocation. And you will work your way up the right side of the spine, going from facet to facet, basically checking the posterolateral margin of the disc and the facet on both sides. Again, this is just creates a little bit more of a comprehensive assessment of the patient's spine and their ability to tolerate this procedure. All right, the next procedure is central tolerance testing. We're now going to lock the table and put on the ankle restraints. The ankle restraints, you want them to go snugly around the ankles. Okay, and then you're going to take tension out of the lower extremities by extending the ankle section and locking it in. Perfect. All right, then we're going to carefully release the table, and we're going to go right back to central tolerance testing, grasping the spinous process. Now there's going to be a significant addition to the amount of traction that is going to be applied to her lumbar spine. Thenar eminence, slide off the sacrum, lock in the L5 spinous process, get your center of gravity over the patient, lock your arm in so it's just a solid rod, and then equal scissors movement. When you find the area of elastic resistance, go slightly beyond it, hold for 4 seconds, inquire for provocation, and read body language. And during that 4-second period of time, try light, medium, or heavy pressure. Okay? Release, ratchet up to L4, and repeat the procedure. Equal scissors movement, find the area of elastic resistance, go slightly beyond it, inquire for provocation. Play with your pressures, light, medium, heavy pressure. And then you're just going to work this up to L3, L2, and L1. After that's all completed, you will have come up with a treatment start point for that particular patient. So basic interpretation, let's go over this. Let's say we have the restraints on, okay? We'll say we're on L5, and I'm applying a medium amount of pressure with the restraints on. And I say, Shannon, how are you doing? Is this increasing your back pain, increasing your leg pain and her numbness? And she says, yes, doc, that is increasing my pain. So what I would do, because I've got medium pressure, I drop down to light pressure. Again, we've got the restraints on, light pressure. I say, Shannon, how are you doing? and Shannon says, that's a lot better, I think I can handle that, that would be your treatment start point. So in your notes, you would write down that the patient could handle the addition of the restraints and light pressure. However, if at that light pressure point, Shannon said that is still too much, then what we're going to do is lock down the table, and we're going to release the restraints, and then we're going to go back to our central tolerance testing. And so now there's no restraints, and I'll say we've got heavy pressure. Shannon, how we doing? That's too much, Doc. Medium pressure, how's that? And Shannon says, that is better, but I think it's still a little too much. And I go to light pressure, and I say, Shannon, how we doing? She says, I think I can handle that. And so in this particular case, we would make a note that we're not using the restraints and a light amount of pressure. So the treatment start point would be no restraints, light pressure. That's likely where you're going to find most of your patients fit in. As you assess the overall terrain by doing central, lateral tolerance testing and central testing again with the restraints on, generally for the acute patient with a disc-related lumbar spine disorder, they're likely going to fall into the category of no restraints and light pressure. And then, of course, throughout the course of their treatment, you would be able to increase that. So as healing takes place, you'll find that you can apply more pressure and eventually even use the restraints. So everything is done sequentially. You have to start at a very tolerable point for the patient, and then as they heal, as they improve, as the symptoms subside, you can then increase the amount of pressure and use the addition of the restraints. And that is a basic synopsis of tolerance testing.